Okay, well, I'm Stefan Holubar. Thank you very much for the opportunity to speak to you all tonight. This is a topic that's very near and dear to my heart, and it should be to all of ours. It's bowel preserving surgery, which is what I call, many of us call the sine qua non of surgery for IBD and for Crohn specifically. Sine qua non is Latin for the essential condition, a thing that which is absolutely necessary, without which not. And we're going to talk about all different types of strictureplasties tonight. I have the following non-relevant disclosures. And the overall outline is that we're going to talk about some overall concepts and then dive into some nice surgical video techniques videos about Heineke-Mikulicz strictureplasties, the use of calibration spheres, and then the non-conventional strictureplasties, the Finney, the isoperistaltic side to side, also called the Michelassi, although he doesn't like to be called that, the Jabelet, small bowel resection, and duodenal jejunal bypass. And I actually added some slides in about the meta-analyses about long-term outcomes and a couple alternatives to strictureplasties as well. And we're going to talk all about the different strictureplasties that you see, these beautiful illustrations that Joe Pangrace, our longtime illustrator at Cleveland Clinic, his beautiful artwork he's made. So we take a step back and we talk about the goals of surgery for IBD. You know, the overarching goals of IBD surgery are to, number one, prevent and treat life-threatening complications, but thankfully that's not that common. For the most part, it's about improving patient quality of life. But for jejunal ileal Crohn's disease patients specifically, we also have to think about, maintaining their bowel length for their, which is hopefully a very long life. And so it's often a balancing act of, we may not be able to cure the disease, but we can control their symptoms enough to give them a good quality of life. Now, the role of surgery in Crohn's disease is very different from ulcerative colitis. It's not curative, as we just mentioned. And the indications for surgery are most commonly fibrostenotic complications, as well as penetrating complications, a little bit less commonly, with the most common presentation being, small bowel obstruction with failure to thrive, although fistula and abscess, bleeding, and neoplasia we also see. Now, the overall concept that we all need to keep in mind when on the strictureplasty topic is that the hindgut is a lifestyle organ. This is what I tell my patients: you're about to lose their entire large bowel. That you don't really need it to have a really happy, good quality of life. However, the midgut we know is needed to maintain nutrition, and thus Crohn's patients with small bowel Crohn's are at risk of intestinal failure and short bowel syndrome, which is a prevalence of about 20,000 persons in the U.S., and probably more than half of those are from Crohn's disease. The definitions vary a little bit on what you read, but in general, less than 180 centimeters of small bowel is putting you at pretty high risk for needing supplemental parenteral IV fluids, if not nutrition. And we have a lot of patients that struggle with this. I will say I have multiple patients with around 100 centimeters of small bowel and all of their large bowel who are doing okay. And there are some breakthrough medications, some next generation GLP-2 analogs like the Gadex type medications. I have one patient with 30 centimeters of small bowel, and he's eating, which is really amazing. So stay tuned for those newer medications. And then the other thing that's really important to think about in Crohn's patients is that we're always doing combined medical surgical therapy, and in this case, bowel preserving surgery. We're not really operating in isolation. These patients need to be medically managed by experts, as they do by surgical experts. Overall, the phenotypes of jejunal ileal Crohn's disease, it's, I would say 100% are inflammatory. And then next common after that, most common surgical indication is fibrostenotic, which is about 25% of patients overall. And penetrating is also about another quarter of patients. Jejunal ileal Crohn's is a less frequent phenotype, thankfully, about 10 to 15% of patients overall, but they're extremely high risk. Their recurrence rate is essentially 100%. Even with the modern medical therapies, they often require reoperation, and thus this is why bowel preserving approaches are so critical for these patients. Now, this is one of my favorite slides, and I would take a screenshot of this This is Bruce Orkin, who was a alumnus from Mayo Clinic Fellowship from way back when, and he did this beautiful anatomic study in patients with going laparotomy for colorectal cancer, and he measured their small bowels, and he found that on average, most people had about 506 centimeters of small bowel, plus or minus 100, which is pretty amazing. A little bit more. I think most of us think it's about 400 centimeters. And patients want to know how much is that in feet, and it's about 16 feet. You can see a range from 9 to 27 feet. And then this study did show that men on average have about 50 centimeters, about 1.5 feet more, and that height was the only predictor on multivariable analysis associated with increased length. Now, we don't just jump right into surgery for Crohn's disease. We want to make sure these patients are optimized because they often bring multiple risk factors for complications to the operating room table. And we're talking about optimization periods as the situation allows for at least 2 weeks or longer. And we really push a lot of exclusive enteral nutrition these days. And this typically is something like a high calorie, high protein, commercially available shake. And I just tell them to just take, 4 of these, 400 to 500 calorie shakes a day as much clear and full liquids if you want, but really avoid the food because the patients with strictures, the food is going to get stuck in the stricture, but the full liquids are going to make their way through. And once they stop eating solid food, they actually feel better. And then they can take the nutrition that they need orally to switch from this catabolic weight loss state to an anabolic, where they're at least not losing any additional weight. And often will gain 1 or 2 pounds and be very sick of whatever brand that they stick with in terms of protein shakes. And if they can't tolerate that, I do a virtual follow-up at a week later to make sure they're tolerating, because if not, then I admit them to the hospital for initiation of home parenteral nutrition. That usually takes about 5 days in the hospital to get that started and set them up for home TPN. Now, importantly, the EEN is, a mono diet, and it's less antigenic, we believe. And this is why it seems to be that EEN actually has anti-inflammatory effect that's equivalent to steroids. And so often, these patients are presenting with some malnutrition and they're also on steroids. And so the EEN allows you the time to then wean the steroids to as low as you can preoperatively, and also to replete their iron. I do not prescribe oral iron on extremely rare circumstances. I prescribe a lot of IV iron. I would say 90% of my IBD patients get intravenous iron when they're in the hospital, and I try to get it to them while we're optimizing it preoperatively. And then other things such as smoking cessation is important, referring them to, IBD psychology if you're lucky enough to have it like we do, or, for cognitive behavioral therapy. Nicotine substitutes are not acceptable. That's the nicotine which causes the, vasoconstriction. Now, importantly, we don't really feel that we need to hold biologics or immunomodulators. And we actually just submitted the revisions to the big NISQIP study yesterday, actually. So hopefully that'll be coming out a little bit later this year. But upadacitinib, there is a signal in the rheumatoid arthritis literature for increased venous thrombembolism risk. And for this reason, we hold it for 3 days preoperatively, and it has a very short half-life. And then, just like we don't, we talked about the team approach before in terms of making sure they're on biologics and advanced therapies preoperatively and postoperatively. We have IBD MDT meetings and we review the cases. We make sure we elicit and obtain the previous operative reports. And hopefully, if they've had strictureplasties before, the surgeon has measured and made, detailed notes of what they did. And then obviously the path reports and all the other ancillary data that, you need to review ahead of time. This is a nice chart that Leo Dreas, one of our young staff members, put together for this publication a couple years ago. And like we talked about on the left, we preoperatively review the previous notes and all the objective data that we have. We try to optimize them. And then intraoperatively, we talk about mapping and documenting how much small bowel they have. I personally use a umbilical tape cut to 40 or 45 centimeters. Sometimes it's a little bit shorter, and sometimes we have to use something else if the umbilical tape is not available. But you want to make sure you really measure how much small bowel they have, how much you resect, and where all the strictureplasties and anastomoses are. And then importantly, you want to assess for other strictures because these patients usually have more than one, and both CT and MR enterography underestimate the stricture burden by about 10%. So usually you will find one or two more strictures. And then, then you have to think about what are you going to do? Is there a cancer? Is there a fistula? Then typically that's going to require a resection, although it's not in the slides, but there is a modification. I think it's called the Neumeyer Stricturoplasty technique, where you can core out the fistula on an innocent bystander loop, and then still do a strictureplasty I think it's the Neumeyer-Moskowitz procedure. And then, the line horse of the vast majority of the stricture is going to be short, on the order of less than 5 centimeters. Getting 10 centimeters is a little bit lengthy for a Heineke-Mikulicz. Some people describe a double Heineke-Mikulicz. But then, when you're getting more than 10 centimeters to something like 15 to 20, then you're really talking about, can you do a Finney? Should you do a Finney? We'll talk about that. And longer than that, you're really talking about a Michelassi, and we'll talk more about that. Now, there's a couple adjuncts on the right there that we have to talk about. And one is the placement of clips, just wet clips on the mesenteric margin on the side of the bowel. And we'll show video of this. And this is because for two reasons. First of all, the majority, almost all of these are hand sewn. We don't staple strictureplasties because the staples are made for a fixed bowel thickness. And as you'll see in some of the videos, the strictures are actually variable thickness. And so it's probably a little bit dangerous to do, although I've done it and others have done it and reported it. In general, we avoid doing stapled strictureplasties. But we do place the clips because of that reason. They're hand sewn, so we like to know where they are. But more importantly, Dr. Scott Strong in particular has written about that if they have a bleed, right, because these strictures usually have a mesenteric marginal ulceration intraluminally, and these patients can bleed from that. And theoretically, you could help to localize the strictureplasty by having a clip there. Now, the other thing we talk about if you have a suspicion, and both of these are selective adjuncts, is about biopsies. If the patient has really long-standing disease, you're going to have a lower threshold to biopsy the stricture. And obviously, if it's abnormal in appearance, when you get in there, you're going to try to do a frozen section or just, go ahead with a cancer operation. And then the most, because you can have, malignant small bowel adenocarcinoma inside these strictures. We'll talk a little bit more about that later. Now, selective diversion is probably the most common question I get asked by our fellows and other trainees. And basically, the bottom line is that you should divert based not on the number of strictures, but on the number of risk factors for leak like you would in any other patient. Things like malnutrition, steroids, anemia, smoking, all the risk factors that we talked about trying to optimize. And part of the reason is because it's no small feat to, it's easy enough to bring out a jejunostomy, but it's another thing to care for that patient who's going to have temporary short bowel syndrome and intestinal failure with high output jejunostomy requiring TPN until such time that you can close that jejunostomy. So it's not something to be taken lightly. I mean, if you have to divert them, you divert them and deal with the TPN. But I think Scott Steele at this point has done the most out of any surgeon. I think he did 26 strictureplasties in a single patient, and that patient did not have a stoma and did not leak. So again, not the number of strictures or number of strictureplasties, but the number of risk factors for leak. Moving on, we're going to kind of start to dive into the actual types of the strictureplasties. And like we mentioned, Heineke-Mikulicz is by far the most common. And some of the contraindications are confluent or tandem strictures. And I think you'll see a photo of that a little bit later, where they're just too close. You need, when you finish the strictureplasty, you need at least a couple centimeters between the strictureplasties. And so if they're just too close to each other, it's just not an option for a Heineke-Mikulicz at least. And then we talked about, if there's penetrating disease, if it's really inflamed from a phlegmon, this is not a situation where a strictureplasty is going to heal properly. And obviously malnutrition and neoplasia we talked about already. And then, most importantly is the bottom half of the slide where what's the overall concept? Overall concept of the strictures opened longitudinally and closed transversely, such as this beautiful Joe Pangrace illustrations that Dr. Fazio had commissioned by Joe. And on the one on the left bottom, you can see those ulcerations that are prone to bleed both intraoperatively and postoperatively. But for some reason, we don't really understand the pathophysiology of these small bowel strictures, but they seem to become quiescent. There's got to be some kind of microbiome. Maybe Ben Chogan will figure it out for us sometime. So here's a video clip. This was published last year in Colorectal Diseases. So it's just a clip. All of these are going to be just clips of the full videos, most of which have been published. That just shows we getting in sharply. And then this is just illustrating the interrupted sutures and probing the suture line for gaps at the end and making sure there's no gaps. And in this particular case, there was two stricture places that were pretty close, so we could palpate it. And then we try to do a dilute betadine test, and this video almost got rejected because you can see here, I really push. I do a lot of this, so I could get away with having two Heineke-Mikolicz's that close to each other, but that was pretty close. That's about as close as you can get it. And that probably should have just been served with a small bowel resection and anastomosis, and we'll show some videos of that later. So again, I encourage you to look at the full video if you're interested in learning more about these texts. They're all pretty quick videos. Now, another one of our favorite adjuncts that we talk about that we like to use is these calibration spheres. And I got this idea from, this is not my, well, part of it's my idea, but Dr. Lavery had picked up a Bakelite ball from an open air market in Spain. And he used to use these Bakelite balls and he used to keep it in his office. And I don't think he got sterilized that much, but it got washed. I know that. But when I came to Cleveland Clinic about 9 years ago, I kind of wanted to, do something better than the long Baker tube I've been using at Dartmouth that they discontinued making, which is basically just an ultra long small intestinal Foley catheter with a balloon, if you will. But I poked around on Amazon and I find these, these nice little calibration spheres. This is a glass sphere. I have some of these spheres sitting in my office. This is a very heavy one, a titanium one. It's really heavy, but these are stainless steel, and you can sterilize them and reuse them, and they cost about $10 for a pack of 10. And these particular spheres are 3/4 of an inch, which is 1.9 centimeters. And basically, you can see these illustrations from Dr. Fazio of you put the sphere in, you run it up, and then if the ball won't pass, then you do a strictureplasty. And it's really important not to force the sphere because you will cause a microperforation and they will get a leak in a intercutaneous fistula. So you got to be careful. And the reason this is important is although most of the strictures will have stigmata on the outside of the bowel, not all of them will. And sometimes these patients get these discrete ring-like diaphragmatic intraluminal strictures that you otherwise wouldn't know was there. And then they're going to have post-op the same symptoms that they started with. And then they may get referred somewhere else, and then someone else may find a stricture that you missed. So always be very thorough looking for these strictures. And for reference, there are a number of different sizes of these calibration spheres. And just for reference, the adult colonoscope is 1.3 centimeter. So sometimes I do use there are smaller spheres that I use for smaller people. And here's a video clip that Leonardo Dreis and I put together when he was a fellow. You can see the balls being put into the open end of the bowel, and then it's being run up. And that was actually a strictureplasty that Dr. Hull had done in the past, where it got hung up. And then here we just show the video of taking some biopsies of the thickened bowel, sending off. This is a patient who had the disease for a long time. And then here you see just an illustration of putting the wet clips for radiographic localization postoperatively. Now, you'd think there's not that much new in Heineke-Mikulicz strictureplasties, but Jenny Moon, one of our fellow who just graduated a couple weeks ago, she and I put together this video that was just published this month in DCR about pouch inlet Heineke-Mikulicz strictureplasties, and Joe made these beautiful illustrations for us. And I think we have time to go through the entire video.
Heineke-Mikulicz strictureplasty. Crohn's-like disease of the pouch may result in afferent limb or pouch inlet strictures with obstructive symptoms. These fibrous ductal strictures may be refractory to advanced therapies in endoscopic wound dilation and may require surgical intervention in the form of pouch excision or reimplantation of the afferent limb. However, isolated short-segment pouch inlet strictures may be amenable to Heineke-Mikulicz strictureplasty. Strictures should be relatively short, less than 5 centimeters, and longer pouch inlet strictures may require resection and reimplantation of the afferent limb. Contraindications are the same for Heineke-Mikulicz performed in the small bowel for diffuse jejunal Crohn's disease. In this CT enterography, we see a short pouch inlet stricture with proximal bowel dilation. Preoperative pouchoscopy reveals a tight stricture of the pouch inlet with associated inflammation and ulceration. A diagnostic laparoscopy may be performed to run the entire small bowel looking for other strictures and skip lesions. Intraoperative pouchoscopy is performed and the distal extent of the stricture marked. A laparotomy or fan and steel incision is made and the stricture opened longitudinally, both proximally and distally onto normal bowel, but only nominally onto the proximal pouch body to avoid subsequent pouch inlet kinking. Stay sutures are first placed at the corners, and the main difference between a pouch inlet strictureplasty and a typical Heineke-Mikulicz is that the pouch is fixed in the pelvis so that the stay sutures are crucial to maintain exposure. The anerotomy is then closed transversely with one or two running or interrupted layers of absorbable suture, and we prefer a second layer of horizontal mattress sutures known as Halstead sutures. At the end of the case, a pouchoscopy with air leak test may then be performed, which also confirms patency. A diagnostic laparoscopy was performed, which revealed the stricture with creeping fat and proximal bowel dilation. We start the strictureplasty with a fan and steel incision, and a wound protector is placed, taking care to make sure that there's no loops of bowel trapped under the protector. An intraoperative pouchoscopy is performed to identify the stricture and especially to delineate the distal extent of the stricture, which is then marked with electrocautery. A full thickness anerotomy using electrocautery is performed, and here we can see we're extending it proximally onto healthy bowel and then a little bit more distally onto healthy bowel. After the longitudinal anerotomy is completed, it's ready for transverse closure. We then replace the Alice clamps with stay sutures in the corner, which are seromuscular stays, and this helps to keep the anerotomy open in a transverse manner while we place the sutures to construct the strictureplasty. First, we use the anerotomy to introduce a calibration sphere into the bowel lumen, which is then run proximally to rule out subtle ring-like strictures in the proximal bowel. We then begin the transverse closure, which is full thickness interrupted sutures in this case, and here you can see the bowel where the stricture is quite thickened as the needles pass through. Each suture is tied and cut as we proceed. Here we see the second stitch being thrown, and again you can see the bowel is very thickened, and in this particular case, we started at the corners and then worked towards the center. However, an efficient strategy is to start in the middle with a bisecting stitch and then proceed according to the rule of halves. This allows each surgeon to start in the middle and sew towards themselves so they can sew and tie in synchrony. When the transverse suture line is complete, a single tine of the DeBakey forceps is used to probe for gaps, which are then closed with a tweener stitch. Next, an outer layer of Lempert's sutures is performed. However, recently I've transitioned using Turnbull sutures for the outer layer, which are a horizontal mattress suture and approximates the edges of the serosa atop the anastomosis very nicely. We then perform a completion pouchoscopy to assess the patency of the strictureplasty as well as perform an air leak test. Pouch in
All
the
right, I think
Heineke-Mikulicz.
that's enough. Okay. So that was Heineke-Mikulicz and Heineke-Mikulicz pouch inlet. We're going to move on and talk about Finney strictureplasties, which are these typically a rare, non-conventional strictureplasty. Like we discussed, these are for moderately long, 10 to 20 centimeter long strictures, and the contraindications is similar to Heineke-Mikulicz, with the one additional caveat that this is now an antiperistaltic reservoir in a patient with diseased bowel. And so some people feel that, Finney's are just not a good treatment in this particular patient population. The overall concept is similar into that the stricture is open longitudinally. However, it's not closed transversely, it's closed in a side-to-side manner. And there you can see the in the illustration, it's been folded into a U with a very long enterotomy. And then first, the two inner walls are sutured to each other, and then the two outer walls are sutured to make the front wall. And I have a video demonstrating the Finney to show you. This is otherwise unstoppable. So we do Finney like that. Right next to me. And we're going to tie the tails together. These usually do require multiple sutures, so you do have to use multiple sutures with the tails tied together. And here you can see we're doing a betadine leak test, and you can see in that last shot was nice because you could see that the patient had multiple. Usually these patients you're doing multiple Heineke-Mikulicz's and/or small bowel resections at the same time. You can see at least 1, 2, 3, 4, or 5 different Heineke-Mikulicz in the same patient. Moving on, the next type of non-conventional strictureplasty is Michelassi, and these are very rarely performed, and these are for long strictures. The contraindications are the same, but I kind of joke that the relative contraindication and the lack of sewing expertise. And the concept is that the two adjacent segments of bowel are open longitudinally after incising the mesentery so that they can then be overlapped and then hand sewn in an isoperistaltic manner. And if you look at the illustration in the top right, you can see what I'm talking about in terms of incising the mesentery. And this is a little bit of a tricky situation because the mesentery, as you all know, is not normal. It's diseased with Crohn's disease, so you have to be exceptionally careful. I will state it's a good time to introduce the concept that, if you do a strictureplasty and it doesn't come out technically the way you like, it's either too tight or it's leaking or whatever, the alternative is that you're going to resect it anyway. So, and sometimes that we do that. We do a strictureplasty and it's technically imperfect and we decide to just cut it out. But so it's something to keep in mind if you're doing a Michelassi, when you make this mesenteric incision, so the bowel loops will advance, one will advance over the other. You may compromise the bowel and get it or get a hematoma and be forced into a resection, which is what the patient would have gotten anyway had you not tried a strictureplasty. But you can see from the other illustrations that after it's advanced, just like in the Finney, the inner layer are sewn together as the back wall, and then the outer layer is sewn together as the front wall. And this inset just shows the trimming of the end to make a taper to fit the taper at the incised end of the opposite end of the enterotomy. This is a video we haven't published because it's not the greatest quality, but we have a little bit of video to clip to show you nonetheless. And you can see this looks like a mess. And here we've lined up the bowel in the back, and now we have some clips of us sewing the inner layer and then transitioning to the front wall. It's very similar actually to the Finney in some regards. And then we leak tested at the end, and you can see it actually looks like a big J pouch. And it's pretty big. Looks very similar to actually probably more like an S pouch. Moving on, we're going to talk about small bowel resections, and you can see the photograph is a patient that I had done half a dozen or more strictureplasties on, and the patient was unable to be compliant with medical therapy and had very severe recurrence. And these strictures were now just too close to each other to do strictureplasties. So sometimes you have to do the small bowel resection, what we've already talked about. So in these cases, I usually do end-to-end hand-sewn enterostomy because it uses less bowel than stapling. And similar to the others, I use 3O slowly absorbable sutures. Dr. Bruce Wolf was the chair of Mayo where I did my fellowship, and he liked 3O PDS, and I just learned to love it over the years. I'm typically do an interrupted back wall with the knots facing down away from the lumen, and then a running continuous inner layer starting in the middle of the back wall and then finishing in the middle of the front wall, and then an interrupted front wall layer. And like I talked about, I've recently switched from working with the transplant surgeons when they repair enterotomies, they do these Holstead sutures. And I've switched maybe a year and a half or 2 years ago now to doing my enterotomy repairs and also the second layers for my anastomosis using these nice horizontal Halstead sutures. I think this is a little bit of a longer video.
Taking care to make sure the incision is big enough to accommodate the thickened bowel and mesentery. Here we see the entire disease segment has been exteriorized. Next, we demonstrate to proximal and distal margin where there is non-thickened bowel with non-thickened mesentery. We then measure the disease segment, which is about 30 centimeters in this case. The bowel is then transected sharply between clamps over betadine silk rag. We then secure the entire cut edge of the hypervascular thickened mesentery using large #1 absorbable horizontal mattress sutures, taking care to stay relatively close to the cut edge to avoid devascularizing the proximal and distal segment. That the mesentery is secure, we're ready for our anastomosis. We then note a slight luminal size discrepancy, and a cheadle slit is performed on the smaller side antimesenterically using electrocautery. We then see the size of the lumens are matched up nicely. Here we're taking the last bite at the corner, and the knot is then tied and the tail snapped as a stay suture. And the back wall, the continuous running inner layer, which is full thickness in the middle of the back wall. The knot is tied and the tail. As we progress, we find that there is a dog ear left over from the cheadle slit, which is excised using electrocautery, completing the inner layer. We finish the anastomosis by performing an outer layer on the front wall. This is traditionally performed using Lembert sutures, although we have recently transitioned to using Halstead stitches are recovered on an enhanced recovery pathway and typically resume or initiate advanced medical therapy for their Crohn's disease.
Okay. Moving on, we're going to switch topics a little bit now and talk about some very atypical strictureplasties. And the first one is the Jabelet. And this is very uncommon. It's for second portion of the duodenal strictures. And I usually do these in conjunction with hepatobiliary surgeons, or they often will do them without me. The concept is that the duodenum proximal and distal of the stricture segment is open longitudinally and then overlapped over the stricture and then closed transversely, right? Because the whole idea is that you can't resect this area because it's too close to the papilla, which we'll talk about a little bit more in a second. So there you can see in this first illustration on the bottom where the stricture is, and so you're basically doing a bypass in front of the stricture after you've fully cochlearized the entire first, second, and third portion of the duodenum. And this is another new video that is not quite made it into the journal print yet, although it's been accepted. And the concept is very similar. This is just a clip, but you can see that here they're placing the feeding tube, and they also place a biliopancreatic tube so they know exactly where the papilla is at all times. And the anastomosis is constructed very similar to how we showed in the other cases and instances. And then they do get an upper GI series a couple days later and then begin tube feeds. Finally, we're going to finish out the technical part of the discussion with the duodenojejunal bypass. And this also is very uncommon. The issue, this is for patients with third or fourth portion of the duodenum strictures, which is otherwise difficult to resect. And the contraindications are same as in the other cases. And we feel that the duodenojejunal bypass is superior to a gastrojejunostomy because it decreases the risk of dumping and also a marginal ulceration. So for this reason, we prefer, if possible, to do DJ bypasses. And the arrow on the, we don't yet have an illustration of this, so this is a little bit of an older case. But this illustration here shows you what we're talking about, where we're bringing a loop of jejunum up and anastomosing it to the third portion of the duodenum. And here's a stop action video that goes through some of the steps. There you can see the ligament of Treitz where the stricture is, and the duodenum proximal that was also strictured. And here you see the duodenum on the left and the jejunum on the right. They're brought next to each other and secured to each other with a back wall, and then mirror image enterotomies. And then you see the mucosa pooching out. And then again, we're doing a full thickness running inner layer, coming around to the front wall, and then finishing the front wall on the middle or towards the end of the front wall, and then finally interrupted front wall, second layer. Now, I'm going to finish up with some slides that I put together looking at all the different meta-analyses and systematic reviews that are some of the highlights from the literature. And spoiler alert, we're going to finish early, so you guys will get a few minutes of your night back. But when I was in your shoes, when I was a fellow, this paper just came out from Paris-Tekis, Vic Fazio, and Dr. Yamamoto. And this was really ruled the roost for a long time and taught a lot of people of my generation. This is how we practiced and what we knew about strictureplasty from this study. So there's about 1,000 patients with over 3,000 strictureplasties. And you can see that the vast majority were Heineke-Mikulicz at 80%, 10% were Finney's, and about 5% were isoparathaltic side to sides. And you can also see that vast majority were in the small intestine, although rarely we do ileocolic strictureplasties. I've done 2 this year, but they're very, very infrequent. And then also we talked about the duodenal strictureplasties, and colon strictureplasties are probably the rarest of all of them. And I would add that, I actually am contemplating a rectal strictureplasty on a patient, believe it or not, but I'm not sure it's going to work, but it's worth contemplating. But the safety of these strictureplasties is really very high in properly selected patients with a septic complication rate of about 4%. It's a great number to remember. And the surgical recurrence rate of about 23%. And that's probably on the low side, to be honest. Like, all of these are, not exceptionally long-term studies. And then they did do a meta-regression for 5-year recurrence, and the recurrence after strictureplasty was 28%, but 90% of the time they recurred at a different site. And this is one of the kind of big teaching points from this slide, is that the majority of the time they're going to recur at a new site, not where you did the strictureplasty. The strictureplasty gets altered. We don't know why. It's something to do with the microbiome, but they tend not to recur. Although I have had to redo strictureplasties, like in that one I showed you that Dr. Hull had done one about a decade ago. On the other hand, they showed that the site-specific recurrence rate was only 3%, which really goes to the durability of this. The other thing that really stands out in my mind from this seminal manuscript is the risk of small bowel adenocarcinoma. It's extremely rare and it's extremely real. If you don't look for it, you're not going to find it. And actually, one of the patients in this study, Bob Sema, one of my mentors in my fellowship, had contributed. He thinks it was one of his patients. So I haven't seen one at a strictureplasty set, but I know one surgeon who has, and I've certainly seen a fair amount of ileocolic anastomotic small bowel adenocarcinoma. So I think as these patients are treated with more advanced therapies and are living longer due to secular improvements in medical care, we're going to be seeing more small bowel adenocarcinoma in longstanding Crohn's disease patients that had disease for 30 or 40 or 50 or longer years. Now, this is the newer meta-analysis that I came across in preparation for this talk. And this compared, looked at studies that had strictureplasty versus bowel resection. And this is by a really great group out of Ireland, actually. What they found was that in this study, about 43% had strictureplasties versus 56% who had bowel resection with or without strictureplasty. So it's a little bit kind of a mixed bag there. And what they found was that the increased likelihood of disease recurrence was with strictureplasty compared with bowel resection. It was statistically significant, although it looks a little bit like the confidence interval is pretty close to 1. And that patients who had strictureplasties alone had a reduced recurrence-free survival, meaning quicker recurrence, compared to those who had bowel resection, suggesting that the bowel resection and hence really the anastomosis is more durable to recurrence than the strictureplasty, but there was no difference in mortality. So their conclusions were that strictureplasty should only be performed in those patients with Crohn's strictures that are at high risk for short bowel syndrome, which I would say is all of these patients. That's why you're doing a strictureplasty. So it's kind of funny. But it's interesting anyway. I mean, and it's true. Like maybe this will come up in the Q&A. If a patient comes to me the first time and they got 5 strictures in 10, in a 30 centimeter segment, like in that video, I may well just do a small bowel resection and then if and when they recur, then leave the strictureplasties for the future operation. And so another relatively new meta-analysis is from my dear friend Andre de Hoor at the Amsterdam Medical Center in Belgium, and his colleagues, and they looked at these non-conventional strictureplasty, and that's actually this paper is where I got that term non-conventional, because it's just so much easier to say non-conventional than constantly referring to Finney's and Michelassis, etc. So this meta-analysis looked at 26 studies of the 1,800 patients. And again, we see there's this mixed bag group. Like in reality, the groups in the middle is the ones who get a combination of this strictureplasty. But nonetheless, they categorize patients into just Heineke-Mikulicz, mixed or purely non-conventional. And the post-op complication rates were very similar between the 3 groups. The septic complications were also very similar between the groups. And the overall surgical recurrence rate was a little bit higher for the Heineke-Mikulicz compared to the other groups, but the statistics didn't really pan out. I mean, this is more of a descriptive study. Finally, I'm going to finish with 2 more meta-analyses, and you have to think in your mind, what else can we do other than strictureplasties and resections? And our GI colleagues have new tools. They have endoscopic balloon dilation, and they have stents, and we're going to talk about both of those as we start to finish up. And this is a very nice meta-analysis by Dominic Bedenworth, a relatively new friend of mine from Germany, as well as my dear friend Florian Rieder, who's one of our IBD gastroenterologists and the wunderkind of small bowel Crohn's disease. He's developing antifibrotics. He's really quite a genius in that regard. Anyway, this meta-analysis of endoscopic dilation for gastroduodenal Crohn's showed that the efficacy and technical success was extremely high, and that the major complication rate was quite low at about 2.9%. And however, whatever you want to say, the bad part about the study is that about 70% of the patients had a recurrence, which is really high, and about 1/3 of them required surgical intervention. And these findings jive with how I see patients clinically. Often when faced with a gastro or a duodenal stricture, we will try to get them dilated. We want to get good biopsies from inside the stricture to make sure it's not a small bowel, a duodenal cancer. And then we may dilate them a couple times, see how they do, and assess if they're a good risk for surgery. And then try to do either a Jabelet or a Heineke-Mikulicz or a DJ bypass if we can, to give them a more durable response. And finally, the endoscopic stenting is kind of the newest of the meta-analyses in this space. And I was very surprised to read this. Came out a couple years ago, because before this, there was very, very few studies. There was nothing really written about this, just a couple of case reports. So this was a total of 9 studies, and this is from Gersman Kochar, who's in Pennsylvania, and he looked at 9 studies with 163 patients, and they included both the traditional self-expanding metal stents as well as new biodegradable stents. And I think this is really interesting, where the field is kind of progressing, because these biodegradable, potentially drug-eluting stents may be where the future is heading for these patients. They found that the clinical and technical success was not quite as high as the balloon dilation for the duodenal ones, at about 60%, and 90% for the technical success. And repeat stenting was required at about 10%, which is pretty low. However, everything has its however, right? Stent migration is very, very high. I think 43% is pretty low. And in fact, we just stented a patient last week with a ileorectal anastomotic recurrence that was refractory to balloon dilation. And a week later, the stent is still in while we're trying to optimize her for surgery. So we'll see what happens. But there is a meta-analysis shown on regular balloon dilation for small bowel Crohn's strictures. And the main thing is that you have to be aware that there is about a up to 10% major complication rate, with the perforation being the most feared one. And my interventional gastroenterologists typically get me involved when they're planning on those dilations, so that I can be ready and available, and they know that I'm in town if they're going to dilate one of my patients, lest they get a perforation, which is not completely unexpected, to be honest. It happens. So finishing up, for these poor patients with diffuse jejunal ileitis who are really high risk for short bowel syndrome and intestinal failure, we use a combination of strictureplasties and bowel resections to preserve as much bowel length as they can. This is one of my cases, and this patient had a total of 26 strictures. And this photograph really illustrates the pseudosacculation really nicely, where you can see it gets ballooned out because you have a proximal and a distal obstruction. And so you get this kind of sac in between the two strictures, which parenthetically lends itself to then working with the bowel and doing strictureplasties. Actually easier often to do the strictureplasties than anastomoses. Sometimes when I get bowel that's dilated, I'll do a circular end to side or side to side in the small bowel, because I just hate making the long GI side to sides and that really dilated, floppy, thick bowel. Anyway, this particular young man got 11 hand-sewn Heineke-Mikulicz, 1 hand-sewn Finney, 1 hand-sewn small bowel resection. We did place a G-tube. Dr. Hull wasn't personally involved in this case, but she popped her head in and was like, "You're going to put a G-tube, right?" And so we did. We placed a gastrostomy tube, and the patient did well, and he did recur. And he's not yet had more surgery, but I'm sure he will. I think this is our last slide. Bowel preserving surgery, the sine qua non of inflammatory bowel disease surgery. In diffuse jejunal Crohn's disease, surgical treatment is based on the principle of using bowel preserving surgery techniques whenever possible to avoid long-term risks of short bowel syndrome and to maximize patient long-term quality of life. Thank you so much.
Thank you very, very much. And I believe we all have the pleasure of having you next week as well for another topic. So I'm sure all the listeners are excited in anticipation of that. We do have one question in the chat, and then I have a couple questions of my own if time permits. But the question in the chat is, do you all tend to approach these in an open fashion? What is the role for laparoscopy or robotic approaches?
That's a great question. So, up until recently, yes, we usually do these laparoscopically to, if the patient has had previous surgery, to basically do an adhesiolysis, and then we can deliver the bowel onto the operative field. I think in one of the videos you could see that the incision was pretty small, about 4 centimeters. So for the first timers, I may or may not put a laparoscope in to do a top lock myself and to look around a little bit, but you don't really need laparoscopy to do it. I mean, with a full, I'm not sure why, but the vast majority of these patients are pretty thin body habitus anyway. It probably has something to do with the pathophysiology and the phenotype. But almost always you can do it with a pretty small incision anyway. So the question about robotics, that's a good question. I just got back from ESCP in Paris last week, and I got to attend some talks about the Da Vinci, what is it called, the DV5, and with the tactile feedback. I think that the technology is getting there potentially to the point that I would consider it. But like I said, like most of these, you can eviscerate the entirety of the small bowel with a 4 centimeter incision. I don't really see, it's almost technological overkill. But I think in the future, without question, and I think for the HPV guys, that's definitely for them to do the things that they do robotically. I think that is a here and now. Great question.
Yeah, the small bowel just is almost too redundant then on the robot. It would be such a technical pain and exercise to have all that flopping around. But yeah, up in the foregut, it sounds wonderful. And then just before we let you go, one question, when and why would you encourage placement of a G tube when you're doing your strictureplasties? How extensive does your operation have to be for you to clinically in your mind start to consider it?
Yeah, that's a good question. I mean, I think the reason we placed it in that particular patient was that patient had a duodenojejunectomy. But I will say, as you might know, I have a pretty skewed practice with, redo IBD patients. And I mean, just the other day we did an 8-hour case. And, if it's really the patients I put G tubes in are the ones who have extremely hostile abdomens, who they're kind of difficult to manage psychosocially at baseline anyway. They're going to be trying to pull out the nasogastric tube after 5 days. And I know they're going to have an ileus for over a week. I tend to have a pretty low threshold, despite the kind of adage or concept of like, don't make a hole in an unnecessary hole in a patient with Crohn's disease. Um, the patients who really need the G tubes, who get them, they are so grateful. And sometimes, they do have to go home on the G tube, and it allows you to get them out of the hospital after about a week on home parenteral nutrition, as opposed to, an undischargeable situation with an G tube, or then trying to get a post-operative peg tube placed, which is then taking here a minimum of 3 to 5 days just to get it scheduled. And so, but that's not that common, I would say. I think the vast majority of cases, you're not going to need it. But for the, again, for the duodenal, the foregut stuff, I think there's definitely a role. You should consult with your hepatobiliary colleagues and see what their preferences are. I think that the one we showed in the video, I forget if that was a drain me, feed me type situation. I'm pretty sure it was, where they were draining the stomach and feeding the small bowel. So gastric tube with the jejunal extension.
Awesome.
Quick,
Ivy,
sorry, I have another question. This one's pretty quick. Is it no PO iron because of the constipatory effects, or it's just like it doesn't work, like they just don't absorb it or something?
It's a great question. I didn't have time to go into a lot of the specifics, but constipation, black stools, GI discomfort, and it's slow, right? So there's a multitude of reasons. And I think, the bottom line is that IV iron is like readily available and paid for insurance now. People are familiar with it. Patients don't mind. They're getting infusions of Remicade or wherever else it is now anyway. So like, oh yeah, just like when you get your Remicade, you go in and you get to sit down for an hour and get some IV iron, and when you come back and see me in a month, your hemoglobin will be up a couple points. I'm really very liberal with the IV iron. There's a great study from Valentin Nofson, who was a former co-resident of mine a long time ago, who looked at using Nisquip to look at anemia. About 50% of the IBD patients had anemia, and across the board, every complication you look at is increased. And in our VTE study that just got published in GCNR, anemia was culprit, and also in the biologic paper that just got submitted yesterday, DCR, anemia is a culprit. It's one of the strongest independent risk factors for complications after IBD surgery, and we need to be more aggressive about giving intravenous iron. The thing, to answer your question, oral iron works, but it's slow, and we're talking about trying to get patients to surgery in about 4 to 6 weeks. And the IV iron, they get a couple grams in a couple hour infusions, and they're loaded up, and at least we've done that. I will say that the Cochrane analysis doesn't really show that it helps that much, but we're working on a study to look at our own patients, but I'm convinced that it helps.
There's a question in the chat on any thoughts about using barbed suture for these anastomoses.
That's a good question. That somebody asked me that. We had a discussion at ESCP about that last week, and I feel like the consensus was no, that it was kind of too traumatic on the swollen bowel. I think when you operate a lot on the small bowel, one of the things you learn is that it's a lot thinner, and the rectum obviously has got a very thick wall. The colon is thin too, but it's very easy to endoscopically perforate a pouch and a small bowel. We just had one recently in a pouch patient, and so yeah, I'm not sure about the barbs. I'd have to try it in a pig or something and see if I like it. I don't know if there's any data. I'd love that person to share if there's any data.
Are you very strict with like what you consider a stricture? I know this is a very basic question, but you know how like some small patients or some patients just have really small caliber bowel to begin with? Do you do kind of like a ratio kind of test for those patients? Like maybe they just have really thin, narrow bowel and can
It's a great
tolerate that.
question. I think if they have proximal dilatation, that's a dead giveaway, right? Then they're having, what I tell patients is that if you have proximal bowel dilation, now the normal bowel is getting negatively affected by the disease damaged bowel. But so I guess another way of phrasing your question is, if I put the sphere in and I pass the stricture, oh yeah, where'd my sphere go? If I put the sphere in and it passes through a stricture, but I can see the stricture and I can feel the stricture, should I do a strictureplasty on that or not? And Hull and I argued about, not argue, but we discussed it. And some of what you read, like for Dr. Strong and other people, will say any stricture that you find, you should do a strictureplasty on. I tend, in the era of advanced therapies, I tend to be a little bit more conservative. And if I can pass the sphere and it's really quite dilated on both sides of it, then I tend to only address ones that the sphere won't pass. If there's any resistance at all to this thing passing, then I do a strictureplasty. I mean, say pass, it's got to like pass right through it. And sometimes you do see these upstream strictures that maybe the distal obstruction blows it up so that it's now patent, even though there's still a narrowing there or a diseased segment of thickened bowel, but the sphere passes through it, I leave it alone. The other thing is, if you don't have these spheres, you can get them on Amazon, but a lot of Hull use the Foley catheter. Lots of people use the Foley balloon, but the thing I don't like about that is you can't run the entire bowel in one sitting. This is really slick. You pop it in and you can run. Just don't lose it. Don't lose it up the ligament of Treitz or into the cecum through the ileocolic anastomosis that was already there.
Oh, sorry, I know we're at the time, but how close can you get to the IC valve? Does it matter at all? Like Like
That's
where
a very good. It does matter. So I would say the textbook, and I practice according that for this particular point, I'm no different than a textbook. If you're 10 centimeters or closer, do a resection. I just took a patient back from one of my former partners who they did a strictureplasty with right at about 10 centimeters or so, and that patient just never got better. I mean, the good news for this situation is that the decision's made for you most of the time, because most of the time they're going to have an ileocolic stricture anyway. And so you're taking it out. Yeah, the rule of thumb is 10 centimeters. And this has to do with two things. One is the blood supply, that there's, you have the ileocolic artery to the right. So theoretically, there's a little bit of a watershed area between the ileocolic artery and that 10 centimeter mark. And then the other is you're just getting too close to the valve. And to work with it, if you have a recurrence, then that's kind of, it doesn't matter. But the other thing is that if you have a relative obstruction at the ileocecal valve, that you're that close to a relative obstruction, that's then going to blow out that strictureplasty. I like the 10 centimeter rule.
Okay.
Nice. Well, thank you so much for taking time out of your weekend and helping educate us. We really appreciate it. And we're all looking forward to seeing you next week talking about pouch salvage. So thank you very, very much. And we'll see you next week.
Thanks, Joshua and Ivy, for hosting me. It was a great fun and a huge honor.